Recording and transcription has started. Excellent. Okay, we're all over this, Liz. Technology for us. Okay, welcome to our Morning Minds menopause refresher. Thank you for joining us if you joined us online. And thanks for everybody coming, and I'll hand it over to the beautiful Liz.
Thank you, beautiful Sarah. For everyone who's not here, we're having a very nice breakfast. You're missing out, and we wish you were here with us. Yeah, that's good. And you can see my slides. Everyone who's here, perfect. So I have two menopause jokes that my husband, who says I'm humorless, wanted me to share. One was that menopause is like menopause. Just stop. And then the other is that we're like in the process of looking for puppies all the time and always wanting dogs. Yeah. So many paws. Sarah really wanted me to do this talk. She really wants people to have more ease prescribing HRT. There's lots you can talk about with regards to menopause, and I am a little bit HRT focused on this talk. And we'll just get started. It's a lovely room of people. Welcome, everybody. So my gestalt about menopause is very patient-centered. I have patients that are really keen for meds and patients that are really keen to avoid meds. And there is room for everyone. I don't think we should pathologize a natural process. A third of women really don't have many symptoms. We don't have evidence that says really we should be pushing for people to be on estrogen if they are feeling good. Certainly there's evidence it does things. Hormones are incredibly biologically active and they're real, but there's so many lifestyle measures and there's Can you hear, Aggie? Give me a thumbs up if you can hear. Beautiful. And welcome to the other people who've snuck on. I'm not sure when you joined, but we're happy that you're here. I think what has become really clear to me in the last 15 plus years as being a gynecologist is that a lot of women have symptoms that are affecting their quality of life, their relationships, their work before what we would technically call peri-menopause. And so I do really like that term, menopausal transition, because it encompasses the late reproductive years, and people can experience their periods quite differently in their mid to late 40s. And sometimes that's where someone wants help, or maybe someone will want help later in their menopausal transition. Or again, a third of women really do kind of cruise through this without seeking help. In terms of a gynecologic perspective, 70% of my visits are in that menopause transition. And a 30% of my visits are talking about menopausal issues. So I literally do talk about it all the time, which is almost scares me to give a lecture because I think I can get like robotic. All right. This is I'm glad we have some med students. So you guys probably are closest to this, but I do think it's amazing as women, we're just so different from men in terms of how our bodies address having children. So we have all of our eggs when we are 20 weeks gestation. That's our peak number of eggs. And then we have a big culling at birth, a big culling at puberty. And then most of them are not ovulated, but they disappear through apoptosis. So what it means is it's a lifespan, and things, going on or off the pill is not going to affect your ovarian reserve. Things that cook the ovaries would, like chemotherapy, but hormonal treatment in our lifetime doesn't affect our ovarian reserve. This is a graph of two bloods that we do measure FSH and estrogen. And if you look at it, can you see my mouse? Yeah. So FSH goes up. So if you look at these numbers, we kind of use over 25 as a bit of a guide. Some people even choose a higher cutoff, but it does really go up quite a bit. And then estrogen, it looks like it comes in kind of flat. But this is in your 40s, but really it's actually, if we came over here, this estrogen in our 40s would be a little bit high. Women naturally have a slightly higher estrogen in their 40s than in their 20s and 30s. I need to get it. Okay. So in terms of diagnosing menopause, it's pretty much clinical questions. There's very few situations where we need to do bloods, and patients are always wanting bloods. So if someone is over 45 and is having either late reproductive years, like transitional symptoms or menopausal symptoms, we know that that's what's going on. The reason not to order blood is that bloods vary every day from day to day, and it's hard to have a clinical picture of that. If you have someone under 40 and you're not sure what's going on, bloods can be helpful. But because they vary so much from day to day, you're always going to probably get a couple sets. All right, so STRAW is the stages of a reproductive aging workshop. It was used so that in research, we don't have a research study looking at postmenopausal women and late reproductive age women, so that we're talking about kind of the right spot when we do research. It's a very research-minded thing, but I do find it helpful clinically when I'm working with patients, because I think if you miscategorize where people are, you can, and patients are going to do anything you suggest, but you could end up giving maybe a silly therapy for where they are in that moment. So, and then this slide here, so it talks about symptoms. And this is it just actually makes me want to pull my hair out. So when it comes to menopause, the lens of treatment has just been hot flashes. And there are so many other symptoms to hot flashes. So when I'm like description, characteristics, symptoms, it's like, I'm like, you guys are just crazy. People are just crazy. So that late reproductive menopausal transition, women are having a lot of symptoms, but they're just not having hot flashes. Okay. And then this is looking at women who are in their 20s and 30s versus older women who are in their 40s. And I just want to show you that the estradiol is quite a bit higher. So I think sometimes women will come in their 40s and be like, I feel so different than I used to. And they think, well, maybe it's because I have so much responsibility, my kids, my husband, my job. And that's probably true. They're probably not prioritizing themselves as well as they could, but also their hormone, their cycle is different than it was previously. It's not just their lifestyle, it's both. And then there's this thing called a loop phenomenon. So as your cycles can get shorter, you can every now and again have a cycle where you just have an enormous amount of estrogen. And you'll see this with women. Not every period is the same, and they might have a period where they just have an enormous period with just like really heavy bleeding. So you occasionally get these cycles where you have out of phase popping up of estrogen. So in that late reproductive window where your estrogen's a bit higher, there are symptoms that come with that. So the 40s are kind of the decade of the migraine for some women. And you can have more nostalgia. And you can have fibroids that are growing more quickly. Maybe someone had fibroids for 10 years and they didn't do much. And then in their 40s, they start growing more quickly. It's also a setup for hyperplasia. So if you have, maybe you've had a PCOS patient who's never been great, doesn't like to be on progestins, hasn't cycled regularly, but they've never developed hyperplasia. And then in their 40s, they might develop hyperplasia. So these are a whole list of symptoms of menopause. And some of these are clearly when your estrogen's declining, like on that original graph way back here, you do have that drop in estrogen. So you get real symptoms here. But then in that late reproductive years, right in here, you get some high estrogen symptoms and just some symptoms. Just your cycle's a bit different. It's a bit shorter. And so, like if I was kind of dividing, like low estrogen symptoms, so hot flashes, night sweats, vulvovaginal dryness. The vulvovaginal stuff generally is years after menopause. It takes a while for that to really kick in for most people, but some people have the world's most sensitive vagina and are going to start noticing things earlier. Joint and muscle pain. Often this is short-lived. Often it's a window of years, and then people really do start to feel better. Skin changes are probably ongoing, and I didn't even put it on the list, but there's a lot of skin changes with low estrogen. And then you aren't ovulating, and you get these really irregular periods before you stop having periods. And then the late reproductive window symptoms is kind of these bottom four, I would call symptoms associated with that kind of enriched estrogen state that's slightly higher than your average estrogen state when you're in your 20s and 30s. And then PMDD, that's just, do you know what PMDD? What is it? 3 months from this far? Yeah. So it's a little bit different than PMS. So PMS is where your estrogen and your progesterone drop 3 days before your period, and you feel you have symptoms from that. So you might, it's almost like a tiny little mini baby flu. So you might have insecurity, irritability, puffiness, some crampy pain. PMDD is where as soon as you ovulate, you feel different and you feel bad. So anxiety or depression. And we just see a lot more of it in your 40s than we do earlier. Certain people in their 20s and 30s can also have PMDD. But people who didn't necessarily have it in their 20s and 30s can give a pretty good story of PMDD. And it's actually a little bit tricky to treat. So we will talk about that in a moment. Right. So we are going to do some cases, case-based. So that's my little intro, and we'll go through some cases. So the first case I have is a 51-year-old who her periods are all over the map for the last year. And she's had no periods for the last 4 months. She's hoping this is the end for her. And for a year, she has had hot flashes and night sweats that are affecting her quality of life. She naturally is someone who hasn't really, who's been suspicious of taking hormones. She's not really jumped at it. She's known it's taken her a year to come see someone. And she really is keen about knowing about the risks of hormones for her. She's a rather healthy person, and she doesn't have a significant family history of breast cancer. So Des, Angela, you would see this patient all the time.
It doesn't for all day. Yeah, exactly.
So when it comes to vasomotor symptoms, you can see the line at the bottom. So about a quarter of women really don't have many symptoms. A quarter of women have symptoms before and after. A quarter of women have symptoms kind of before menopause and then they settle. And then a quarter of women have symptoms after menopause. There's a lot in the literature, like I can just give a whole talk on this. Lifestyle does make a difference a little bit. Diet makes a difference a little bit. Your BMI and your weight and exercise make a difference a little bit. Not drinking too much makes a difference. So certainly how you cope with vasomotor symptoms, lifestyle is a part of it. But it's it's not something that's going to cure you either. So it is like, it's something you can start with, or it can be motivating, but it's like, it's taking the edges off of things. There are a lot of different treatments for climactic symptoms, hot flashes and night sweats. And there's actually a lot of research. So one of the consultants that I worked with at the University of Washington was Susan Reed. And she did a lot of research on like black cohosh, like good studies looking at some natural therapies. And none of them really panned out in the literature, but you certainly will like meet people who have had improvement with some naturopathic things. And then in terms of meds, there are some psychogenic meds that seem to be helpful to people. Oxybutynin is interesting because it is something that helps you if you have urge incontinence or an overactive bladder. So sometimes that's a nice thing to try because it can kill two birds with one stone. There are also some non-pharmacologic things. There are some pain doctors, some interventional radiologists that will do blocks to ganglia that can make your hot flashes less of a big deal. So there's a lot to that, but certainly the thing that I would say works the best and works the easiest is estrogen. So hormone therapy. King Eddie's has nice guidelines for starting all of these. All right. So when we talk about medical management or medical hormone therapy, we're describing giving estrogen to treat low estrogen symptoms. So that could be issues with your bone, issues with genital urinary syndrome of menopause, issues with hot flashes and night sweats. And then whether or not you have to have progestins to prevent the uterus from having the lining that just keeps growing depends on whether or not you have a uterus. So if you have a uterus, then you do need progestin or bioidentical progesterone. And if you don't have a uterus, then you can have unopposed estrogen. And in general, for this patient who has risks, who wants to know all the risks of HRT. So if you are on estrogen, then we worry about cardiovascular risk. And if you also on progestin, then we worry about an increased risk to your to an increased rate of breast cancer. So I'm going to spend quite a bit of time talking about that right now. All right, and then this is a slide that comes from the American Menopause Society about how much and what progestin is enough to suppress or to counterbalance the estrogen in a uterus. And they have a continuous version and a cyclic version. So here is medroxyprogesterone, which we just don't use anymore very often. And then there's micronized, which is bioidentical progesterone, which we're using quite a bit of, and norethisterone. And there's lots of others. Pretty much any progestin that we're using, you can use for menopause. We're using it off-label. But if you are starting with someone who doesn't have a problem uterus and you're monitoring that, I'm happy with any progestin. Even things like Bizan, I think could be fine. Slinda is fine. Marinas are fine. Any progestin is fine. And we're going to argue for the next 20 years on how low can you go. So like a Marina is way more than you need. What about Kylena? I think it's fine to try Kylena. I'm on this menopause group though, and I'm one end of the spectrum. I'm just not afraid because someone's going to present with bleeding and you can do a scan and see if the lining is thick. So yeah, of this list, I would say, and this theme will come out, I would say the thing about choosing which progestin is really where they are in their straw grid, because you are postmenopausal, any progestin is going to work. And if you are premenopausal and your estrogen is already high, you need contraceptive doses of progestins to control bleeding. Or you can do something cyclic and have a monthly period. All right. In terms of cardiovascular risk, this is something that was very confusing when I was in training, and it's just not confusing anymore. So We, in the 80s and 90s, physicians got all excited about HRT because they thought it would improve women's cardiovascular health as they aged. And they saw benefits like improved levels of cholesterol, less heart disease, and stroke. And then the Women's Health Initiative came out in 2001, and it was like high rates of heart attack and stroke. And then it took us 20 years to tease out that data, but we really have. And we now have 20 years of great, beautiful studies from Europe, not pharmacy or not corporate driven, like government driven studies. So what happens is if you start HRT near menopause, you are getting some cardiovascular benefit when you're on it. But if you start HRT and you're remote from menopause, you do increase your risk of some kind of clot event that can either cause a heart attack or a stroke. So when you start, it really matters. And then the other thing that is very clear in the literature is transdermal is just way better, and especially the closer you get to 60. I think it's very, like if we have women who are on oral estrogen or estradiol near 60, it's like there's data saying that's not safe. So now what's tricky about topical estrogen is not everyone loves it. A lot of people don't mind it, but not everyone. So sometimes women will have skin damage and they just have to use like 3 or 4 pumps, and they're not getting that much estrogen in, but it's just what they need to get it in. And that just adds up for that person because they're just burning through their bottle. Patches are great, but not all brands are equally good. Like the Vidal Dot has a really nice adhesive, but like the whole world wants the Vidal Dot. I think they're like made in France, and so it can be hard. Like my wealthy neighbor in Sydney always has her Vidal Dot. I don't know how she's getting it. So there. Other patches, are like this big and don't have a very good adhesive. So, and then patches and broom, I just don't think they work. We're just all in and out of water. But transdermal is really better. So for that woman, I would say you're a perfect age to have some cardiovascular benefit and no harm. And especially if we can find a topical estrogen that you like. I know that Sarah likes them to be really practical. So John Eden, who's a menopause guru in Australia, who's really why Australia has bioidentical estradiol, progesterone, testosterone available. Like we don't even have that in the US. He has said that the company says the pharmacokinetics of estrogel is the best if you apply it right here. Then I have a lot of crossover, right? Like women are having kids older. I have a 6-year-old who like starts the night in her own bed and ends up in my bed like on me, so it's like I don't really want her getting my estrogen. So you can have like I think for most people it's using it in the morning. If you work out, then have a shower and use it. But you just want a 2-hour window where you're not sweaty or getting in water.
And it's supposed to again, you're supposed to put it there, because I'm not charging to put it there.
You can, if you read it, it says you can put it anywhere except your boobs.
Yeah.
And within, like, they don't really want it on your belly, but so your ass, your legs, your arms, all that's fine.
I still get it,
I wouldn't put it on my face, but people put a vesting on their face. But I think in terms of like the most even pharmacokinetics, so like if you did an hourly blood test, the company thinks that the big part of the leg is the best.
That's why it's just a child line. Really good.
Figure there, and it's
Yeah.
I love it.
Watch the presentation out there.
I think breast cancer risk is harder to talk about, but probably pretty important to talk about. And you really can't talk to a woman about their specific risk of breast cancer without looking at who they are, everything. So breast cancer is common. This is what the UK says. And I guess I'm gathering that that NHS just doesn't want to pay for HRT. So this is the most pessimistic view of breast cancer ever. And I do share this view with patients, but I also will share another view. So they think that estrogen only HRT, 1 in 200. And then they have 1 in 50 and 1 in 70.
So these are all women with uteruses.
Yeah, well, the bottom one isn't. The bottom one is estrogen only. So the combined, these are combined. And then if you take it for 10 years, so this is for 5 years. So what's interesting about this is they've excluded 2 really good randomized controlled trials. So they kind of cherry picked the most negative case. So if you look at, this is a really good French study that they left out, 78,000 people. There was very little additive risk with bioidentical progesterone if you were on it under 5 years. And then if you're on it for over 5 years, they have a 1.3. So, and then the Women's Health Initiative, and they stopped the Women's Health Initiative because they were getting such a high rate of breast cancer. In the estrogen only group, they actually have less breast cancers. And then if you got a breast cancer, you were less likely to die from it. So John Eden thinks that if we really look at everything in the pathology of where breast cancer comes from, it is more progesterone, it's etiology. But then estrogens cause it to grow. So you're gonna have something bad in you, and it's gonna flare up. And he thinks that's why, because a lot of women who will have children in their 40s will get diagnosed with breast cancer. And he thinks it's the same thing. It's not that being pregnant is necessarily causing the breast cancer, but it's causing something that might have presented in their 50s to pop up. But it is, it's interesting. I have come, and this is the American Menopause Society, and look how low that number. An extra case of breast cancer for every 1,000 women years of HRT. So if you divide by 5, that would be like 200 women on HRT for 5 years. So it's and that's progesterone and estrogen as well. So it's a little bit tricky to put all that together. At this point in my life, I do kind of a customizable risk thing where I look at relative risk. So I use the Gail-Coleman calculator, which has like how old you were when you got your first period, some family history, how old you were when you had your first kid, if you've ever had breast masses that have required being biopsied. So if you've had a breast biopsy, your risk of cancer is higher, even if it was benign, but just says something about how your breasts are kind of prone to growing, I guess. So, so this is a 5-year risk and a lifetime risk of getting breast cancer. And then I kind of go back to this table and we look at the modifiable risks. So for me, bioidentical progesterone, I tell people a relative risk of 1.6, which is more negative than the French, but not as negative as the UK. And then for progestins, I'll say at most it's a relative risk of 2. And the thing about progestins is it's probably that relative risk even in your 30s if you're on contraception. It's just that your baseline risk of getting breast cancer in your 30s is so low. So like 0.1 something times 2 is, 0.2. Where when you're if you're 55 and your risk of getting breast cancer in the next 5 years is, 2 times 2 is 4%. So and then even then, I think patients struggle to know what this really means. So I do love graphics, and I keep hoping I'm going to find like a little app where I can pop in a graphic. So this is my risk of getting breast cancer in the next 5 years. I did this a year ago, so it's probably changed a little bit. And then this is my risk of getting breast cancer in the next 5 years if I have 2 standard drinks a day. So there's a lot of things that affect our risks, not just the HRT. So it's really, for me, it's patient-centered decision making. This is a 56-year-old with a first-degree relative of breast cancer. And this is that same 56-year-old, not looking at alcohol or other things, who is on HRT. So you can see there's lots of blocks that don't have that color, but I do think sometimes that visual thing is helpful for people. So going to, these are my take-home points. I think we've been through them. Okay, so for this woman with her irregular periods, her low estrogen symptoms, and so from a cardiovascular standpoint, she's a really good candidate to go on HRT. And from a breast cancer standpoint, she's a really good candidate to go on HRT. So she is still having some bleeding. So she's someone who I would put on cyclic HRT as opposed to continuous HRT because I think she's going to spot, not for long, maybe the next year and then transition, or I put her on a contraceptive dose for a short time of something and then it maybe in a year switch to bioidentical progesterone. So she could have Mirena with estrogel and that would probably take away her bleeding pretty quickly. Although we, one of the things is when you start a progestin only therapy, you are going to have spotting for 3 months. And that's Linda, that's norethistro, that's Mirena. So,
Kind of the way that's technical.
this is an area of debate. So on my little hormone, I'll tell you a story. Last night I was like Googling things in my WhatsApp from this hormone little channel I'm on. And I got a text from a friend and I had like pocket texted at 9 o'clock my time, which would have been 11 o'clock. Well, text with Korean characters. I was like, oh my gosh. But there's such a big debate because people say 5 years. I'm like, that's just crazy. If you look at a Mirena and you look at the pharmacokinetics of it, it has this long, even tail. That's why we're using it for contraception through 8 and beyond. So I think there's no reason to say only 5 years.
I'm on it. I didn't go. I'm just on the line.
There we go. All right, beautiful. Okay. Any questions about that case? All right, beautiful. All right. So, and then this is just a symptom scorecard. I really do like the AMS website. I find it really friendly for me and for patients. I use it a lot. But I think sometimes things don't have to be perfect to be better. So it can be nice just to have something like this to kind of keep track of how things are going. Okay, this is a different case. This is a 55-year-old who has a new diagnosis of osteoporosis. That's a really dramatic compression fracture. But anyway, and she had hot flashes, but they settled. And in the last 4 months, she's developed a lot of vulvar dryness and some urinary frequency and some pain with sex. So we now group all those kind of epithelial symptoms from the genital area, genital urinary syndrome of menopause, which is just the hardest thing for me to remember. But it is a nice little catch-all. All right. So what are you guys thinking? Vaginal estrogen, tick, correct. This is a picture of the epithelium of a well estronized premenopause state and a low estrogen postmenopause state. And with that thin epithelium, we see urinary frequency, we see more recurrent UTIs, we see a perception of vaginal dryness. You're just sitting and just feel kind of dry and itchy. And you have more pain with intercourse, probably more thrush too. You're just, the tissue's just so thin, it's prone to micro trauma from toilet paper or sex or anything, and thrush loves trauma. And yeah. Okay. And there is a lot of different ways to get vaginal estrogen. Here we have Ovestin, which is E3, which people like. People feel good on it. It's hard to overdose that. I'm a big fan of Ovestin. There's estradiol, the little pessaries, which I actually like too, but I hate the plastic introducer. There's probably ways to get vaginal estradiol, they're just not easy ways to do it. in the US, we have this lovely ring that would fit in your vagina for 90 days. So you have 4 rings a year. That was kind of nice. If you look at all of them, the amount of estradiol in your serum is super low. And there's such good data. This is safe for anyone, even if they have a family history of breast cancer. And then the question is it safe when someone has had breast cancer? And that is a harder question to answer, and one that people really have different opinions about. So someone like John Eden is like, go for it. Oncologists are the most conservative ever. They don't want you to go for it. I'm often like, what if you're on a chemo prevention agent? Can you give a little more estrogen down there? So I feel like a good part of my time is politely advocating for patients with oncologists about the time estrogen. It is not black and white. It's certainly nothing I would do without talking to the team. What type, how aggressive was the cancer? Was it hormone receptor positive? All those things play into it. But I do think there is a fear of vaginal estrogen a little bit out of proportion to the data. The data is quite reassuring. And then options for osteoporosis. I'm not an osteoporosis expert. I had to study osteoporosis for my American boards, and I just don't ever really treat osteoporosis ever in this country. I'm really behind the times. There is the bisphosphonates are really common, and estrogen works really well. It works as well as bisphosphonates. So who is a candidate for estrogen to prevent secondary fractures? I have a position statement here that's from the British Menopause Society and ACOG. And essentially they're saying if someone's under 60, we have data on the risk benefits and alternatives of HRT. And if you have someone who's an okay candidate for HRT, it's acceptable to use HRT to prevent their osteoporosis from having a fracture. But if you have someone who's not a good candidate for HRT, use something else. That's my take home point. And probably the GPs in the room have a more nuanced take home. Anything to add?
Discuss with the patient. So I've had a look recently and I went through the health with them and showed them, they're on HRT and they can just continue the HRT with long-term vulnerable density.
Yeah.
Or we could start with bisphosphonate. But
Yeah.
bisphosphonate is not without risk and the HRT is beneficial
Yeah.
and allow the patient to be guided.
Yeah.
But they
And the thing about osteoporosis is if you live to 90, you're going to be having like 40 years of talking about this. So maybe you do estrogen for 15 of those years, and then maybe you do some bisphosphonates in their 70s. Bisphosphonates are not, they're fine until they're not fine. It's like the side effects are like catastrophic, rare but catastrophic. So I trained with someone whose dad was a dentist, and she's like, that jaw necrosis is not that rare. What are they calling it?
Osteoporosis.
Yes. So it sounds really rare, but it's not actually that rare. So
Really? The next.
say it again.
Motion.
Yeah. And you have to go to PERC for that.
have to go to the.
Wow, that is such a.
But come at both hands.
And twice a year.
Every 2 years.
Every 2 years. I misheard you. Okay, that sounds better. All right. So I think for her, with her GU symptoms, she should be on vaginal estrogen no matter what. And then she can have a patient-centered decision on, there's a lot you can do for her bones. So diet, exercise, weight bearing, those vests. So there's a lot to have that conversation just besides drugs. And if you're looking at medical intervention, HRT for her would be a really reasonable thing. Okay. All right. And then in terms of, because of her age, she could be on continuous HRT. She's not someone where I'm like, you're going to spot a lot. It'll be pretty easy to start HRT. And I would go with the safest. So I think bioidentical progesterone is amazing, but I think when you're Perimenopausal, you get a lot more spotting on it, so you really need to cycle with it. So, but she's probably a good candidate for continuous HRT with bioidentical progesterone. Okay, so this is case 3. This is a 4 to 6-year-old. She has a lot going on in her life. Periods have gotten a bit shorter every 24 to 25 days. She just feels off quite a bit in the month. Intense irritability, depression, very puffy. And then her periods are just so heavy, and she just feels like it just almost puts her in bed. And then just when she's starting to feel better, then she feels bad again. And she wants her hormones tested. She feels like something's out of whack. So 4 to 6, we can chase her hormone levels. And sometimes I even order blood because patients really want that. But I just know by her symptoms, her period, her age, she's age appropriate for that late reproductive transition. And she sounds like for 2 weeks, she probably meets criteria for that PMDD. So PMDD is actually very hard to treat. And I remember in training being like, why is this so hard? But you would think so there's 2 modes of treatment. There's antidepressants, or there's trying to suppress their period. And the thing about hormones in the data is it's not effective. You would think it would just fix it, and it doesn't. I think the thing about hormones for some people is you get a contraceptive benefit. Maybe it's enough to make their period lighter, but some people are still ovulating even on hormones. And with PMDD, I don't think it's your symptoms are this and your hormones are this. I think it's like a switch. Something happens when you ovulate, and your autonomic nervous system has this way of being, and it's a switch. And if that switch happens, even if you're adding hormones that might alleviate some of it, the switch has already happened. So people with PMDD, where you give them a med, they stop ovulating. They do feel better overnight. People with PMDD, where they're still having some ovulation and that switch is still happening, do not necessarily feel better. And then when it comes to antidepressants, it's a different thing than classic depression. So an SSRI, you give that as an antidepressant to someone with depression, they have to be on for weeks to notice a difference. But with this PMDD, with that switch, they take 1 pill and they feel different. So you can use cyclic SSRIs as soon as they feel bad. They might be on it for 10 to 14 days. And that can improve people's way of how they feel. You can put someone on a combined or contraceptive pill. It's actually a little bit hard to suppress ovulation with progestins only. So like Mirena, it doesn't suppress ovulation. Bizan, it doesn't suppress ovulation. Slinda, they say it does at 4 milligrams. Norepinephrine, the dose you need to suppress ovulation is somewhere between 2.5 and 10 milligrams. So I think if someone says, like if you start Slinda and someone's saying, I still feel that, they're right. I'm sure if we did like weekly estradiol, you probably would see some evidence that they have some kind of cyclic stuff. So as I get older, I see it. I don't know if that's really in the literature, but clinically I find it helpful that it's like you want to prevent the switch from happening, because once the switch has happened, it's like a different way of the brain being. And it is, so there are situations where I do see people adding estrogen the second half of the cycle. So before you ovulate, you're estrogen dominant, and after you ovulate, you're progesterone dominant. So sometimes people will add estrogen, like estrogel, to that second half. Particularly if people are more migrant the second half of their cycle. Just haven't seen big wins with that. I hear big wins in the headache stuff, but I think for the mood, the PMDD, I don't think people feel heaps better. And then when people do feel heaps better, I'm like, is this a placebo effect? And is it actually more like the conservative stuff of someone knowing it's coming and they do all the things right to live well, not drinking too much alcohol, exercising a little bit, being kind to themselves, giving themselves a break. Their family knows it's coming. Because sometimes just that kind of life preparation is enough to cope a lot better. So there you go. All right. And then we were just talking about menstrual suppression. It's real. You just don't suppress periods with bioidentical progesterone. I'm sure. I mean, breastfeeding, you're suppressing your ovulation a little bit. So there must be some suppression, but it's not very reliable. You need the contraceptive doses of progesterone. All right. And probably the combined options where you also add an estrogen to suppress ovulation a lot better. So the typical pill with ethinyl estradiol, so that's the traditional pill, or Zoli with estradiol, or Nextstellis with E4. And I think she was describing being puffy, swollen. So Linda and Nextstellis or Yasmin, the progestin has that what's the word I'm looking for? It's like a mineral corticoid. So it has that nice it's going to prevent you from being underwater. Struggling, sorry guys. So I think for her, if she was in my room, I would offer her Nextstellis to get the to get that progestin that's so good when you're puffy, and then to suppress ovulation a little bit better than just the Slinda on its own. Patients really don't like cycling with SSRIs, but it works really well. All right, so case 4. So this is a 32-year-old who hasn't had a period for 4 months. She's been trying to conceive for a year and a half, and her periods have been short and irregular. She's tried some progestin day 21 tracking to confirm she's ovulated, and it's just been hard to even know when to get that blood done. And she's having new hot flashes and night sweats. So what are we worried about? So premature ovarian insufficiency, which we used to call premature ovarian failure, and I still sometimes do, but I'm trying not to. So our goals of care for her, the first one is to diagnose if this is what's going on. So we are going to do bloods on her. And we're going to do bloods 4 to 6 weeks apart at a minimum. And most people say do it again in 4 months. And then we're going to do investigations for premature ovarian insufficiency. Some of it's autoimmune. It runs in that family of like thyroid problems and adrenal problems. Probably only several % is that. Sometimes it's genetic. So the woman might be a fragile X mutation carrier. And often we don't know why. And what to test for that is tricky. I found a nice list of the workup on the AMS, and I would just use that if I had a patient, just to tick all the boxes. Up to Date has a nice little guide. And then if she is menopause and she's in her 30s, we need to give her estrogen for her bones and her cardiovascular protection. She has a uterus, so she needs also to be on a progesterone or progestin. She needs a conversation around fertility. So she might be a candidate for a donor embryo or a donor egg. And then if you have that autoimmune POI, it's variable. So sometimes, if she doesn't want more children, if it was a different story, she wasn't trying to conceive, sometimes you actually need contraception. So often the best thing is actually just to be on a combined pill. All right, this is my last case. We have 7 minutes. So she had 3 C-sections and she has poor libido. And I've written this case when she's 45 and I've written this case when she's 52. Helping women with libido is like, it's just so hard. Because they probably are seeing you after they've tried some things themselves, but maybe not. There is certainly, it's pretty common. So women being stressed by their libido, 12.3% between 45 and 60. And it just sets them up for disharmony in their relationship. And they don't want to have disharmony in their relationship. Women sexual response cycle has changed over time. And if you spontaneous sexual drive, so it's no longer considered like pathologic to have no spontaneous sexual drive. If you end up being sexually active with a partner for a number of reasons and you're missing this, it's not necessarily considered pathologic anymore. But it's that I'm like, there's this point where you really don't want to have sex, and it really does not matter how how sophisticated your partner's attempt is to get you that sex. It is just not on. Like there has to be this little open door where it seems like a reasonable idea. So, it is very multifactorial and much more than meds, like having, working on your relationship. Exercise is huge, working on your sense of self, being in your body, eating well. These things are much more important than any meds. And then if you have a female sexual arousal disorder, which we used to call HSDD, if you have that and someone gives you testosterone and you're postmenopausal, the data is that it helps a lot. If you are premenopausal, there's no data for it. So that's another argument in our menopause chat. Like, what is the role for topical estrogen to that 12% of people that feel distressed by their libido under 50? And I don't think it's well established. I also don't think it's that expensive, and I don't think it's that harmful. So I think it can be a really reasonable thing to try. But the data on who it works for are postmenopausal women. This is a pretty good statement. So with androgen, so we're quite lucky, it's bioidentical testosterone. It's at a great dose. You just check androgens to make sure they're not high. You're not looking for a level. You just don't want to be adding high androgens to someone who actually already has high androgens. And then it's a trial. They try it for 3 months. They just rub it on their arm every day. It's not much that you're rubbing on. And you test in 12 weeks just to make sure their androgens aren't high. And then a patient can decide if they think they feel better. And some people's libido might be better. Other people might just feel better and just feel a little bit emotionally a bit better, a little bit more energy. There's some drugs in America for this, but I literally know nothing about them. And I'm very suspicious of them. And there you go. Thank you. Beautiful. Thank you guys. Have a good day.
Thank you very much for this, giving up the time. She doesn't like getting up early in the mornings and everything. So but no, we really appreciate it. Thank you so much.
Have a great day, everyone. Thank you, Sam. Thank you. That's really cool.
I will do that. Thank you.
It's beautiful.